Welcome to Therapy Cafe, the Future of Mental Health Episode 8, Nurturing Beautiful Brains, ADHD and Behavior Management Training, with our guest, Dr. Dylann Gold. ADHD is one of the most common neurodevelopmental disorders of childhood, and it's been one of the most requested topics for educational resources at Psych Hub. Today, we're going to learn about behavior management training, which is an approach for children and adolescents that focuses on teaching behavioral tools to parents, caregivers, and other adults who interact with children and adolescents diagnosed with ADHD. Behavior management training is based on behavior therapy, an evidence-based approach that applies principles of learning to address challenges in psychosocial functioning and reduce distress associated with maladaptive patterns. Today, Dr. Dylann Gold, a clinical psychologist and expert in child and adolescent ADHD and parent and caregiver training, will walk us through the clinical presentation of ADHD and how to leverage behavior management training in therapy. At the end of the podcast, we'll provide information about how you can obtain continuing education for this course. Also, ensure you never miss an episode by hitting the subscribe button. Here's my conversation with Dr. Gold. Dylann, let's just start from the beginning.
Yeah.
What is behavior therapy or behavior management training?
Yeah. So broadly, it's a evidence-based therapy that is based on the principles of learning. And it's generally used to address oftentimes externalizing behaviors, so behaviors that we can see. And for our purposes, when we talk about behavior management training, we're really talking about an approach for kids and teens that is where the parent, the caregiver, the teacher, all of the grownups in their world are the ones implementing this treatment. And we'll definitely get into a little bit more about what it all means. But really, it's helping the adults be the primary agents of change in the treatment.
Okay, good. I mean, it makes a lot of sense, right? So it's a good way to kind of start. So when we're talking about BMT with relationship to like ADHD, like why is it a good fit for it?
Yes. So kids with ADHD have sort of very specific challenges that really lend themselves quite well to this model. First, they have a hard time self-monitoring, which really means just being aware of and in control of your behavior. And that's a really important piece. And when you think about, individual therapy, oftentimes there does take some awareness and self-monitoring in the moment to be able to implement strategies. And that's why oftentimes we recruit caregivers and teachers to really help, because it's really hard for kids to kind of monitor themselves. It also makes it really hard. We'll talk more about generalization later, this fancy word essentially meaning doing different behaviors across settings. It's hard for kids with ADHD to generalize behaviors across different settings. And so we really want to help by kind of all the adults being on the same page and implementing these behaviorally based, learning based strategies to really make it something comprehensive. And also, and lucky for us, because we have this treatment, kids with ADHD are very susceptible to environmental contingencies. So basically the if-thens, the cause and effects of their environment. And so lucky for us in the sense that we have a treatment where we can really help kind of change and tweak the environment to make them more successful. And also it can be really challenging if that environment doesn't really comport with what they need. So that's where us behavior therapists come in to really help adjust things.
It sounds so interesting. It sounds like consistency is going to be key in it.
Huge. Consistency is kind of the biggest piece here. Because if you think about it, kids with ADHD are sort of, it's like there's a deficit in this prefrontal cortex in their frontal lobe. It's like having an air traffic control center, and most of us are able to, be able to kind of monitor and know what's going on around us and plan and all of that. And for kids with ADHD, decision-making, problem solving, planning next steps, all of those things are really hard because of those deficits.
So I want to understand, like what is the clinical understanding of ADHD and the criteria But I'm also curious when we talk about autism and it being a spectrum and that people can fall in that spectrum. Is it also the same with ADHD?
Totally. And I would say really anything is a spectrum, right? We see people with anxiety where there's a spectrum of severity, right? Same with autism. We might see different, more severe symptoms present kind of on the higher end and then something more subtle on the lower end. Same goes for ADHD. And actually we often specify, whether we're seeing mild, moderate, or severe ADHD. So that's a really good question. And sometimes it is significant enough where, boy, oh boy, in pre-K, they're really being flagged because there's a lot of symptoms going on. And then sometimes you get kids who are sort of a little bit lower key, a little more inattentive, who don't get diagnosed until they're in high school and things start to catch up. So it really does range. But at its base, ADHD is a neurodevelopmental disorder. And we can't scan for it, right? We can't take pictures of somebody's brain and say that is an ADHD brain. Not yet, anyway. But what we can do is we could take large groups of scans and of people with ADHD and compare them to large groups of scans of people without ADHD.
Oh,
and
wow.
we do tend to see some differences in the way the brain looks.
Wow, that is really fascinating. So can you help us understand the difference of ADHD and ADD?
Sure. And I'll tell you a little bit more kind of just about the symptoms of ADHD in general. So it is a disorder that is comprised of three core symptoms. We have inattention, we have hyperactivity, and we have impulsivity. And each of those three things sort of has, inattention would be things like distractibility, difficulty focusing, often losing things, having a difficult time staying on task. Hyperactivity would be having a tough time staying in your seat, pacing around and moving around a lot, kind of for a lot of younger kids, climbing inappropriately or sort of running around like you're on a motor. And impulsivity would be things like calling out in the classroom or interrupting other people, a push or a shove without ill intent, but just sort of as an impulsive kind of behavior. It's where sort of the behavior kind of skips the part where you mull it over and think, is this a good idea? So those are the main three criteria. And then we have subtypes of ADHD. So we'll have predominantly inattentive subtype, and those are people who are meeting criteria for those, hitting a lot of those inattentive symptoms. We have hyperactive impulsive subtype, which are, again, kids who are meeting those symptoms, but not quite the inattentive stuff. And then we have a combined type ADHD, which it encompasses both. It's where kids are really struggling with the inattentive piece as well as the hyperactive impulsive piece. Now, your question for, ADD versus ADHD, they're essentially, it used to be the case that we would differentiate that kids who are more on the hyperactive end got an H and kids who are more inattentive did not. That it's really just sort of an outdated kind of way of talking about it. And so that's why we call it all ADHD. A little confusing if you ask me, but then that's why we have those subtypes.
Okay, so ADD is kind of passe.
Yeah, a little bit.
Okay, great to know. So I would imagine that there are a lot of very common challenges for kids of ADHD and their caregivers. Can you share a little bit of what they are?
Sure. Yeah, and that's what's kind of fun about working with ADHD. It's like you experience, these families who are so overwhelmed and stressed and have these really big challenges in managing their children's behavior and don't know what to do. And oftentimes you're like, oh, I've seen that before. Yes, there's so many commonalities, and we often have really good tools for addressing these because we see a lot of the same kind of stuff. So for younger kids, I see a lot of difficulty following through with basic routines, like getting dressed in the morning, brushing teeth at night, PJs, all sorts of things like that. Things like safety rules, right? So sometimes like holding hands when we cross the street or not running ahead. Those things can really come up, especially in the context of more impulsive kids. Trouble taking turns. Again, when you're more impulsive, you're more likely to snatch and grab things, which is tough. Playing too rough, In the classroom, we have kids calling out and not waiting their turn. Kids just being really, really on the move, again, running ahead in ways that might not be so safe. And just a lot of stimulation seeking and needing a lot of input from their environment. So touching things and fidgeting. And it can be very tiring, particularly because younger kids tend to be more of the hyperactive impulsive. We see that trajectory kind of changing or lessening over time. And so young kids with hyperactive impulsive ADHD can be really tricky in terms of managing some of those behaviors. And then with adolescents, more likely, we see a lot more of the organizational skills, time management, planning difficulties. So things like messy bedrooms, losing books and, cell phones, and leaving things behind, forgetting to follow parent rules, losing track of time. And when you're a teenager, you don't have somebody shuffling around and saying, "Oh, did you put your folder in your backpack?" And so that's where things can get a little bit tricky.
Wow, I can only imagine, because I think it probably goes for all kids, but then you magnify it and it just can make it an incredibly frustrating experience.
Yeah, truly, for both.
So Dylann, can you help us kind of share how this informs a practitioner's perspective of understanding a child or an adolescent with ADHD?
Yeah, so I think it is really important to understand these developmental elements and these sort of brain-based elements, and what are the symptoms? What do we envision kind of as a child with ADHD struggling with? Because kids with ADHD they look normal in the traditional, whatever that means, right? They're bright and talented and wonderful and loving, right? So in order to really access that as clinicians, we need to be able to see that here are the things that are so brain-based, that are so kind of symptom-based, that are getting in the way of their functioning. And we want to be able to lead with love, and we want to be able to lead with some compassion. And if you got a kid who is just hitting their brother all the time, or is disrupting the classroom, or is so smart but really just doesn't get their act together in school, right? All the pejorative kind of things we say about kids who are struggling, they're just lazy, just not a good kid, right? If we can understand that there are true brain-based underpinnings here, and that these are actually kids that really need help, and that there isn't this on-purpose, malicious kind of element to what we're seeing, that then can help us to really tackle the symptoms in a much more thoughtful and loving way, rather than making it be really punitive, which I think is a lot of our instincts.
Yeah, it makes so much sense. Before we get into the evidence-based practice of it, I'm just curious about you. What made you decide to get into this as a specialty?
Yes. So, oh my gosh. So when I was in college, I worked actually through NYU, the summer program for kids with ADHD. And we were in charge of a group of 13, 14 kids with ADHD on a level that required an 8-week, at the time it was 8-week summer program, a behavioral treatment program. And these are kids who had never gotten the gold star in class. They were always on, think of like the red light, green light system often used in classrooms. They were always on red. They didn't win the awards. They weren't getting positive calls from the teacher. It was quite the opposite, right? Constantly being corrected, constantly getting in trouble, and just really feeling not great about themselves because they had some pretty significant behaviors. And so during this summer, I got an opportunity to implement behavioral strategies on a really intensive basis, which included an in-program element with the kids, but also, most importantly, a parent training element with the parents concurrently. And boy, oh boy, to see kids who have never gotten positive feedback just light up, and to see parents watch their kid thrive for the first time. I have chills right now just thinking about it. And so then I was like, this is what I need to do. And then I just I went and I got my PhD, and I was like,
that's amazing.
Yeah.
That is so cool. That is so great. And it's like you saw the power of, if you were trained to do this, the difference you can make in people's lives.
Totally. And it was an 8-week program that was so intensive. And so that you saw the stark differences. We made graphs of progress. I mean, it was in front of you. And so that's pretty incredible.
Wow. So we're going to talk about behavior management training as the evidence-based practice. Has that changed at all since then and now?
Great question. So the general principles have not, right? These are like very old kind of behavioral principles of learning that have not, just simply been around for a couple of years. I do think there is more of particularly for clinicians who are really skilled with the behavioral principles, there's a lot more kind of newer stuff out there that's being incorporated and mixed in. So there is a bit of a misconception, or there has been a bit of a misconception, that behavior therapy can be kind of like robotic, and that it's all about like rewards, consequences. We're not getting deep, right? We're missing something. And that couldn't really be further from the truth. We are working with what we can see, what we can hear, what we can know, right? We're not sort of making stuff up, right? So there is something surface about how we're taking our information and how we're implementing. But we're also, I think, adding a lot more validation. There's more of an effort to incorporate things like mindfulness into treatment. So those things have evolved a little bit, but I also think too, more and more myths about behavior therapy have been dispelled. And so people are realizing that they can operate outside the box, and feelings count too. And that we do talk to kids about feelings, and those are really relevant. So it's not just about like, how many times have you called out in class today? It's also about really tapping into how kids feel and how parents feel. So yeah, I would say not at its core, but generally we've seen some evolution.
Right. And I think that makes, when you talk about your experience when you were in college, that makes a lot of sense, right? Because you could see their confidence, I would imagine, getting better as they were having more successes. So please help us understand the 3 principles of behavior management training.
Sure. So first, I think it would behoove us to talk about operant conditioning. So essentially this ABC model, right? This idea that and we'll talk about the ABs and the Cs. So we have your antecedents, which are anything that precedes a behavior. So any internal or external event or a circumstance, including the circumstance of having ADHD, that precedes or triggers a behavior, right? So we'll talk through an example in a minute. So that's the A, so the triggers, you could say. The B is the behavior. So any action that's specific, observable, measurable, time-bound. So what are we seeing? Sometimes we think about thoughts as behaviors too. And then the consequence. So what happens after the behavior? Consequence kind of has a negative connotation. That's not what we mean. We just mean literally what is the response of the environment toward that behavior. And it contributes to how likely it is that that behavior is going to happen in the future. So I'll give you kind of an example of this model. So you have a child with more of a hyperactive, impulsive ADHD. The behavior is that they break a dinner time rule by getting out of their seat at the dinner table. So they've gotten out of their seat at the dinner table. That's the behavior, because there's a rule about that. The antecedents might be that the child is tired from a day at school. It might be that their stimulant medication has worn off, so they no longer are able to regulate as well. There might be a TV on in the next room. Their iPad's charging in the next room. The child might have just transitioned from something else, and it's really hard to kind of get things together to settle in on something different. And maybe it's that, at dinner, there's something they don't like on their plate. Maybe they don't like broccoli, and that's another piece. So all of that sets this child up, including having ADHD, to be more inclined to break the dinner time rule and get up, right? And so maybe the consequence is that the child gets to glance at the TV or the iPad even for a sec, right? Or maybe they escape that broccoli smell for a second. I personally love broccoli, but this is just an example. And it also, maybe when they get up, it gives them a little bit of a body break or an opportunity to move around. And then they get a lot of attention from their caregiver, who's saying, hey, we need to respect our rules at the table. You have to sit down. And there's a lot of reinforcement by just all that attention they're getting. And so the consequence in this scenario might reinforce the behavior. So when we talk about operant conditioning, it's really the principles of reinforcement and punishment.
So it stems from the classic behavioral operating conditioning, which is, but I
Exactly.
love that the way that you at the ABC model. I think that's really kind of an easier way to think about it. Can you tell us about generalization?
Sure. So generalization is, like I alluded to earlier, is the ability to display behavior consistently across settings and with different factors and people along the way. So if in our example, if the child maybe tends to stay seated through dinner at grandma's house, but not at home with parents, it might be that staying seated at the dinner table is a behavior that is learned well at grandma's and not at home. And that would be a behavior that's not really fully generalized. And inconsistent functioning is sort of a hallmark of ADHD. So what we want to do, and part of the strategies that we implement, is to kind of set up the environment so that things can be consistent across settings. What is the magic juice at grandma's house that decreases the likelihood that the behavior of getting up is going to happen? So that's part of another thing we look at.
It makes so much common sense.
It does. That's the thing. I always tell families this. I am not about to teach you rocket science. Nothing I'm going to tell you is going to sound, a lot of it might be stuff you've already heard, depending on what you've read. Some of the stuff might be new, but a lot of it's intuitive.
Right.
But in the moment, it can be so counterintuitive because you're frustrated.
Exactly.
And there's so many details that oftentimes we need to tweak, but you're right. And that's the beauty of it, is that it is simple when it comes down to it.
I makes so much sense. So what about the last one, modeling?
Modeling. Yes. So essentially what we know from research is that we learn new behaviors by observing other people doing those behaviors. And kids, particularly kids with ADHD, who have a hard time maintaining their focus on one specific thing, are often very observant about what's happening in their environment, and very susceptible to kind of the energy around them, including just what other people are doing and what their behaviors are. So modeling modeling like, oh, I'm going to write this grocery list down so I don't forget what I'm getting at the store, right? Like, as a caregiver, to be able to model those behaviors, you are teaching your child those behaviors.
All right, so I'm just going to keep going here because
Go for it.
This is fascinating. So how would you describe the role of the practitioner for practicing behavioral training as compared to other approaches?
Great question. So I think one thing it really depends on what you're practicing, but I would say it's pretty directive, right? You're teaching skills, right? It's not sort of like open kind of, sort of sit back and sort of see what the person is coming in with. It's very active. So it's a lot of telling the person what your suggestions and your recommendations are. That said, it's not a session of like bossing people around the whole time. It's, we need to kind of also take into consideration what this family's life looks like. What does the school functioning look like? How amenable is the school in terms of like being a part of this? And then, so we tailor it very specifically to what's needed, but ultimately it is a more directive kind of treatment. So I would say that. It is very much based on outside of session work. And so, there are a lot of therapies that include outside of session work. Most evidence-based therapies have that. So I don't like to use the H word of homework. I'll usually say like, you have a little assignment or like something to practice. But so that I think is another really big piece.
So then how do the families and the caregivers react to it? And I guess, are there things that the practitioner can do to help like set their expectations?
Yes. So it really varies. But this is a really good question because the variability in how they come in or what they come in kind of thinking it's going to be really matters here. So when I get a call, some parents are like, I know I need some parenting help, and that's what we're doing. And I might give a diagnosis of ADHD, confirm, hey, this is what we need. and we're off to the races and we're doing behavioral work. Oftentimes, and I would say probably more often, kids are having trouble and parents call saying, my child needs therapy. And their vision of what that looks like is individual sessions with their child. And so I'm very sensitive to the idea that when you come in saying, hey, my child needs therapy, and you then ultimately, after an evaluation, get the feedback of like, hey, so you're going to be the one in the sessions, and this is what this is going to look like, that can be off-putting. It could feel blamey, like, oh my gosh, does this person think that I'm a problem, right? And that's just not the case at all. So that's where we really need to double down on this is what the evidence says is most needed, just like we talked about, right? Kids have a hard time self-monitoring, right? Mm-hmm. And so they need that outside support. So it's not that it's your fault, right? And it's going to be, as the caregiver, part of your challenge to sort of support your child in these ways and make it a lot easier for yourself. So giving that psychoeducation around really why it's important to have parents, caregivers, teachers, adults involved, I think is key. And also to name it, call it out ahead of time, and say, I know you were expecting this one thing. Let me tell you, let's talk about like why this is.
So I know I'm curious, Dylann, like when we're talking here to our audience, our practitioners, behavioral training, I mean, it might be challenging for them. Like, do you have any recommendations or, any things to help them?
Yes. So it's funny. The first time I ever observed someone doing parent training, which was in my summer program all those years ago, I remember sitting there because I was in more of an observational role at that time and thinking to myself, oh my gosh, this parent just asked a question. How the heck is she going to respond to this? What is she going to say? That's a tough one. That's a really tough question. And now that I have all this experience under my belt, I'm like, oh my gosh, these are the questions that families ask all the time. And you start to really kind of like learn how to problem solve those things. So I would say if you are diving into behavioral parent training for the first time, that taking on a client with more functional impairments that are kind of mild, I wouldn't necessarily take on a child who's on the precipice of getting like kicked out of school for your first case. Because that can be really, it can feel, even now, one of the biggest challenges for me is like sometimes in the more severe cases, it feels like a lot more pressure and it feels a lot more time kind of constricted, and we have to, and these things take time. Yeah. So taking on a case that's a little milder would be a recommendation. And also really honing in on the buy-in of the caregiver and problem solving issues that are coming up. So there's a lot of lines that I end up saying a lot, which is like the devil is in the details. It is so about the minutia in this work that the difference between something small and like a little tweak could be like something that really works and is effective and something that could make it worse. So when parents are feeling discouraged, oftentimes I will help them to be like, let me help you problem solve. You've been working so hard. Like this silly little tweak is going to make a difference, right? So having those sort of encouragements at the ready, I think is helpful. And also resisting the urge, like I alluded to earlier, of falling into this like crisis of the moment pattern where it's like, I know that like, brushing teeth was the issue last week, but this week he was so disrespectful. Well, how's teeth brushing going? Oh, well, that's actually going better. Ooh, we have to like really kind of, we want to make sure, like, let's honor that. What was it that helped? Did we talk, like, let's talk about the assignment that you completed. Was that effective? Right. So you don't want to, kids with ADHD are moving real fast. And so we want to be able to really address things stepwise, behaviors at a time. It might sound really tedious, but that's how we get lasting success.
It makes so much sense. It also sounds like a focus could be also focusing on positive things, not just the negative. So giving some reinforcement for some successes. So it's not a constant battle of you didn't do this.
Exactly. Yes. Right. Because this is what kids with ADHD are used to. Well, wait a minute. Didn't you make a whole chart about brushing teeth last week? And now suddenly like, okay, we don't care about the chart anymore. We're all about this new behavior that's coming up, right? So we want to celebrate those wins because momentum is momentum. And once kids start doing really well with certain behaviors, we can then make those behaviors more challenging, stack certain things on top. But it's really tempting. And we understand why caregivers it can be really frustrating because there is never just one behavior that's concerning. That's why you've come to see me. But I want you to workshop using the tools that we're learning with specific behaviors so parents can start to generalize the principles to other behaviors and not see it as reinventing the wheel each time.
Yep, makes the world of sense. It goes back to the, intuitive piece of it. So let's talk about how you would implement it. And, obviously we really appreciate your expertise on this is amazing. And the way that you make it not feel so daunting. I love the way you talked about, go with sort of the lower acuity cases first and, to get acclimated, start practicing on maybe the less complicated ones. But let's just talk about it in practice now. So when you're starting BMT, what does an assessment look like? And how is it used? And are there any standard assessments and tools?
Tons. I think the biggest element that I am trying to do when I am diagnosing ADHD is not simply diagnosing ADHD. I'm not just looking for ADHD because if I am, then I'm missing other stuff. There are so many other things that can look like inattention, hyperactivity, impulsivity that are to the naked eye might look like ADHD. But when you ask some more questions, turns out, that actually makes more sense that there might be an anxiety component there. So we're really doing a comprehensive assessment, something like the CASADS, which is a structured interview that includes anxiety and depression and ADHD, right? It kind of goes through a bunch of different potential conditions. And it allows us to really get information about the timeline. Timeline is huge with ADHD. If a 16-year-old comes in and they're having trouble focusing and there is not a whiff of attentional difficulties prior, that might leave me a little bit suspicious that it might not be ADHD. So I really want to get a good timeline. I really want to get to understand kind of all of the potential pieces of the puzzle. And then if we're really, thinking ADHD is in the mix, there are some very specific measures we can give. The Connors is a questionnaire we often use. The SNAP is another questionnaire. Something called the COSS, COSS, is a questionnaire that can assess more organizational skills specifically. There's something called the ECBI, ECBI, and that assesses mostly disruptive behavior, but it includes some like ADHD specific behaviors in there as well. And that one's really good to assess week to week change in therapy as well. So I might give a parent an ECBI each week to see what direction we're headed, which is awesome. And then also something like a BASC can be a really good measure because that includes elements of ADHD, but it also has anxiety and depression and, other things where you can really kind of get a graphical sense of what else you're looking at. So I'm going to want to do those measures. I'm going to want to do a nice interview. And if families are open, I usually really like to do and encourage some kind of a collateral assessment where I have a conversation with a teacher or, somebody that, an after school program leader that can really also speak to the behavior as well, because we really want to get a sense from multiple grownups what this looks like.
It's so fascinating, all these different assessments. So when you're talking about that, in some cases it might raise a flag to you that it's not ADHD. How do you take that timeline conversation? Does that happen first? And then from that, you decide what assessments to give? Like, is there like an order to how you do it?
Great question. Oftentimes I will give kind of more, maybe like something like a BASC that's more of a broad-based measure up front because it really kind of like, sets the flags for other things. And then I'll do an interview. And then after I've done the interview, and oftentimes like concurrently or after I've even spoke with like a teacher, that's when I'll start to be like, okay, we're really suspecting anxiety. Here's a bunch of anxiety measures, or we're really suspecting ADHD. Here are some more specific measures that are going to zero in on that. So that's a really good question.
So how would you introduce BMT to caregivers? Like now that you've figured out that, yes, this is ADHD and this is the right intervention, do you have like some key points because you're going to have to get their buy-in?
Oh my gosh, buy-in is so key. It's also a time commitment, and it's like there's stuff I'm going to ask you to do outside of session, and it's not stuff that can be outsourced. It really is. There's lifestyle often changes that are involved, and I like to be really sensitive to that. The first step before I even pitch this kind of treatment is psychoeducation, like psychoeducation to the max. We want parents to really understand what is ADHD. They might have a very specific idea of what it is. And sometimes we're really dispelling myths. We're also oftentimes, unfortunately, speaking with caregivers who are so frustrated. And I hear all the time, I love my kid and I'm struggling really hard to like him or to like her.
Yeah.
And so part of it too is really validating that like, just because your child has ADHD does not mean you're not allowed to be frustrated. These are tough moments you're having, right? So helping families feel really safe and feeling really educated about what ADHD even means. And then at that point, I can then add on, and this is what we recommend. Because now suddenly what we recommend is on the foundation of an understanding, and it all then makes sense. So psychoed is so huge, and kind of what we talked about before, coming in with sort of all the evidence and the reasons that are very specifically ADHD based that make it a really good candidate for this type of treatment.
I'm so glad to hear you talk about psychoeducation because I founded Psych Hub on this exact notion of how I think it's so important to become informed consumers about anything, right? But like, why wouldn't you about your health care? Why wouldn't you about your mental health care? Why wouldn't you about any kind of situation? And then there's a lot of not good information, fake news, bad, so to really be able to get, good information, education is key. And then you're right. I think that's so true. Then you feel validated, just like you said, because then you realize it's not just me, other people feel this way, and it just really normalizes so much of it. So do you structure like a session with the caregiver? Yes, there's a structure to it?
Yes. So again, we have to always adapt, right? I want to dispel this idea that it's so robotic and that every session's got to look the same. And first we do this and then we do this and then we're off, right? Like there's flexibility, right? You have to, as a good behavior therapist, forgetting the BMT part, as a good behavior therapist, you got to know when and how to pivot. And so that will be my disclaimer. That said, most effective BMT is a beginning piece of psychoeducation. Then the middle sort of sessions are really focusing on positive behavior strategies. And then the later sessions are focusing more on some of the discipline-based stuff. But within an individual session, oftentimes I'll ask about the week. How did things go? Very kind of quickly, more broad stressors. There's good evidence that checking in with families about broad-based stressors that are outside of treatment is a really good move for making that treatment that you're trying to do more effective. Because if I don't know what else is stressing you out and I don't know why maybe it's been hard to implement, then I'm going to be really banging my head against a wall each week. Like, how can I help them? I don't know what to do. So we check in, we see how things are going. Then we'll check in specifics about how's the treatment going? How is the assignment going that we talked about last week? How's the behavior going? The one that we're working on. We'll problem solve. We'll make some tweaks. If we're at the point that it makes sense to introduce a new tool or a new behavior to target, we'll do that. And then we'll assign some sort of a, task for the week of, what families can do to continue their practice. So that tends to be how it's structured, but it's very loose depending on what the family shows up with.
Dylann, how many caregivers are resistant? And do you have it where I'm imagining you've done this for quite some time, so you've seen themes. Do people just want to put the kids on medication and say, let's just see what the medication does? Is that ever become an issue?
Great question. So actually, it's funny. So from my perspective, oftentimes people will reach out to me within mind that they might be interested in medication in conjunction. They want to kind of see what I think about medication, but they usually come to me because there's some motivation of like, let's see what we can do without medication.
Okay.
And so I actually find myself having conversations with families more often of like, hey, we've done all this great work. We've reached this certain point. There are still some tricky challenges. What we actually know is that the gold standard of ADHD treatment, this is important, is behavior therapy and medication together. Mm-hmm. Does that mean all kids need medication? No, it does not. And I tell families up front about this, and I tell them I'll always be honest with you if I think, you know what? And even if it's milder, there's support for that too. It's really what families are comfortable with. So I actually find that more of my time is spent supporting families in making that decision to go get a psychopharmacology consultation as opposed to the other way around.
Wow. It's encouraging to know because you're asking the caregiver to be your partner in this, but it's also the way you talk about it. You're empowering them. You're empowering them to give them tools. So can you share some of the specific kind of tools that they might learn in BMT?
Absolutely. So one of the first things that we teach parents is, again, coming in with the like, I love my kid and I really struggle to like them, and I have a hard time, interacting and engaging in a way that feels pleasant. So oftentimes we will initially begin with positive strategies. Sometimes with younger kids, we'll implement something called special playtime, where parents will spend one-on-one individual time with kids each day just playing. And through that, we teach parents to use something called selective attention, where they pay attention to the neutral and positive behaviors that their child is engaging in, which there are many, but those don't stand out so much. But we want parents to start telling their kids, hey, thanks for sitting so quietly, or I love the way you're sharing your toys with me, right? And also to pull back a little bit on the negative feedback, right? So when the child's a little bit sort of squirmy or uses a little bit of a tone of voice that you don't quite like, that not everything has to be negative feedback, that you can just simply ignore it and let the moment pass. And then the moment when that child is back to something positive or neutral, that's where you jump back in. Oh my gosh, you're using such a calm voice. I love it when we can play nicely together, right? So that is such a big piece of how we start. We also teach parents a lot about praising and reinforcing behaviors that are the positive opposites of the ones they struggle with. So for example, if a child is struggling with listening and the parent just says, oh my gosh, I have to tell my child literally 20 times to brush their teeth. Man, oh man, if they do it on the second time you've asked, that is the perfect opportunity to praise the positive opposite of not listening, which is, oh my gosh, thank you for listening. Thanks for listening so quickly. So that's another kind of key to that positive piece. And then also we want to identify what are the target behaviors? What are the things this child is really needing to work on? What's getting in their way? And that will come with maybe a behavior plan, which there might be a reward system. And so those are three main prongs. And then we also will sometimes get into, negative consequences, but not ones that feel overly punitive or harsh, but just ones that, are effective, as oftentimes kids with ADHD might need something a little beyond just the positive strategies.
I have just always been a huge advocate of positive parenting anyways, because I just think we all, no matter what we're talking about, we all really tend to get more from positive reinforcement than negative, right? We have so much negativity in our own heads anyways. And it makes so much sense.
Totally. And I think it's important, I think, to really, even the kind of negative consequence element of what we do and what we teach parents, it's actually not about being harsh or punitive in any kind of way. We deliver those consequences in a way that is neutral. So we're not screaming, we're not yelling, we're not getting sassy with kids, we're not giving them the stink eye, right? We are just giving them the consequence that was predetermined from the get-go, that they were made aware of. We're not making impulsive decisions in the moment. Hey, because you hit your brother, you lost iPad time for tonight, right? Tomorrow's a new day. That's it. It doesn't have to be yelling. It doesn't have to be screaming. It's just a consequence for behavior because that's life. We have consequences for our behaviors. So I think that's a really important element, that it does not stray from positive parenting. In fact, we want the consequence to speak for itself. We don't want to yell. We don't want to get harsh. We want to be able to implement in a really neutral and predictable way. So that's the goal when we get to kind of the more punishment-based stuff.
Like, it just feels like for later in life, these are really good skills, because you're right. There are consequences for everything. Like, if you are going to just eat dessert and junk food, and, then you're not going to be healthy. Or if you, when you're working, you decide, oh, I'm going to sleep in and not go to work today or not do the work I need to do, there's consequences. So it makes sense to me that these are also just really good building blocks for success in the future.
100%.
So, does a caregiver graduate from training? Is there sort of like, okay, you've done this, you've made it, now we're good?
Yeah. So the goal of behavior therapy is not necessarily that a family is in treatment forever, right? It's goal-based. So we want families to work toward their goals and achieve them and be ready to move on. A lot of times we will reduce the frequency of sessions or check in because, we all drift. And so, and as kids develop, new challenges come up, right? So there are often kids that I'll be in their lives for an extended period of time, but not because we're doing this intense behavior management training all that time. So what we look for in graduation is that we look for children are functioning better, families are less stressed. Oftentimes, I really like to see those numbers on some of those measures going down. And so we really have quantitative data to suggest that families are ready to move on. And so, yeah, they do. And they can always come in for a refresher and a tweak if needed.
Do you see a lot of themes with parents? I mean, is there something where you start doing this enough and you hear these things and you're like, I know, same, I've heard this before, I've seen this movie before, kind of a thing? Or is every case very, very different?
Both. Totally both. So, definitely there are always families and kids keeping me on my toes. And it is totally normal for there to be elements that feel a little abnormal that don't fit in a box. That's the nature of neuroatypicality. Oftentimes, there might be a little bit of some spectrum features, right? Autism spectrum features or anxiety or different things mixed together and create all sorts of different challenges that could arise. So that's certainly, I'm not surprised by always being surprised, I guess is the best way to put it. That said, though, oftentimes there are major themes that come up, whether it's, for teenagers struggling to get their homework in, right? Or for younger kids, those routines, those morning and evening routines are so tricky, right? So we'll often see the same kinds of themes come up. Another big theme that we haven't talked about is that ADHD is genetic. And working with parents with ADHD, of a kid with ADHD, often means that we're working with parents with ADHD. And whether diagnosed or not.
Right.
And so part of it is kind of recognizing sometimes when parents have some of the challenges with implementation or organization and helping parents to kind of work through that in what you're doing for their child. So it's an added twist, but I am never surprised that a parent might also struggle similarly.
I've always kind of been curious, and I don't know if there's a statistic in this or just generalization of, are most people diagnosed with ADHD when they're young, or do just a bunch of them end up figuring out how to manage through life and get diagnosed as adults?
It's a really good question. I think it's also a question that very much depends on socioeconomic status, unfortunately. Mm-hmm. You'll hear all the time that ADHD is overdiagnosed. It's actually underdiagnosed when you consider the fact that so many kids who are not privileged to have the mental health care that they need are not getting the diagnoses that they need, or they're being diagnosed with something else, right? There's a big bipolar craze for a while where young kids, which is so rare that that comes up in younger children that would always make me furrow my brow.
Yeah.
So kids need a really solid diagnosis. And so, a lot of times we will see certain communities that don't get those diagnoses just as much as others. So the one thing I will say is that because there's so much variability, that's a point I would want to make. That said, though, oftentimes in this day and age, kids are a little bit more obvious when they're hyperactive, impulsive. And so oftentimes you will see those types of kids getting diagnosed more readily. And now adults who maybe back when they were growing up, the mental health care knowledge was a little different, are now coming back. So it's kind of an ever evolving, generationally, an ever evolving answer.
Yeah, I would so imagine, and I have, as you probably do, adult friends, and and kid, I mean the whole age range, and you can see more severity, and sometimes I see it on a cell phone where it's like the lack of patience of just like, wait, like let me press next, and and it's just like you're going 10 steps ahead, and and I have a friend, and he does that, and I'm always just like, slow down. So
yeah, cell phones certainly don't make anyone's life easier when it comes to attention spans.
Obviously we're hearing a lot about ADHD medication. In fact, I think, there's a shortage now because so many people are on it, and you're hearing all about that, and people can't get it. Is there a role that education, psychoeducation can play with medication with medication so that people can learn more about what it is, the effects of it, and all of that?
Yeah. So, as a psychologist and not a prescribing psychiatrist or nurse practitioner, I don't prescribe medication. But I do see my role as being kind of a shepherd to be able to kind of help families who maybe do need that component to get connected with the right people. So it's not my business to really talk so much about like all the ins and outs of the medicine, but just to share what I know, so that families can then build the confidence and comfort level to take that step and speak to somebody who does prescribe medicine. So like I said, it is this kind of the two prongs of behavior therapy and medication. It is one of those elements of the gold standard of treatment. So I will talk to families about that up front. When I make a diagnosis, I talk about medication. Sometimes what I talk about is, I'm seeing how severe this is. I'm seeing how your poor kid is like really close to getting kicked out of school and is struggling with friendship so much. It would be a strong recommendation that concurrent with our therapy that we work on together, our behavior therapy, that you also seek a consultation just to learn more. So there are some kids that it really does feel like it's needed off the bat. You can kind of tell when it's at a severe level. And then there are other kids who I'll say, you know what, this is an option. I totally support that option. Here's what you need to do in order to, we can also see how behavior therapy works, and we can keep that dialogue going if we need to. So I think it's giving some information, because also too, we know that ADHD medications are really old medicines. They've time tested. They're safe. They're very safe. They don't stay in your system. You can try it, decide you don't like it, and never take that medicine again. And that, they are among the most effective medicines in medicine, believe it or not. And so while some kids, obviously that doesn't mean that every child is going to be an amazing responder, but like compared to so many of the other medications we have in mental health and just in the medical field, it can be really life-changing. And so when kids really need that, I see it as my job to help them feel comfortable taking the step to talk to a prescriber.
I love the way that you frame it, which is it's both, because, it sounds like it could just be BMT, could be BMT and medication, but could it just be medication?
I mean, so here's the thing about meds. They don't teach you organizational skills, right? Like they don't, right? There are certain, like, right, they don't teach you all the things that you're missing that you don't know. That said, they do turn the dial down on hyperactivity, impulsivity, and they improve attention in a way that actually makes those concepts more accessible. So oftentimes I will say, and according to the research, behavior therapy and medication are equally helpful, and they're most helpful together. So technically speaking, medication on its own is a great treatment, and there might be some gaps.
But a great takeaway for our learners is both is the gold standard.
Yes, that's the gold standard, and not everybody needs both.
So today we discussed what ADHD is and how it's exhibited in children and adolescents, and the basic principles and structure of behavior management training. So before we end, what is the number one thing therapists should take away from this discussion?
Oh gosh, well, I don't know how much we really hit on this, but I think it's so important, is that because we're doing behavior therapy, right, which there are elements of it that are formulaic, right? Antecedents, behaviors, and consequences, right? We kind of, I think it can often get lost in the weeds of behavior charts, that we want to connect with families. We want them to feel heard. We want them to feel validated. We want to develop relationships with them. And so my biggest piece of advice is, if you are not a behavior therapist or you haven't done BMT before, keep what you already bring to the table, because you want to bring that humanity and you want to bring that flexibility into the mix as well. And then you have this amazing framework that you can weave in there, right? That's the core of what you're doing, but you're delivering that package as a human being and as the awesome clinician that you already are. So that would actually be, in addition to all the stuff we just learned and talked about, that would be kind of my number one piece of advice, is to be you and to be authentic and to bring humor into it if that's your thing, or sweet, soft, like whatever your style is. I tend to be more animated. I use my hands all the time, as you can see. But like, you got to be you when you do this. Otherwise, it will feel really robotic.
You know what? We told our listeners that they were going to be in for such a treat with you, and you did not disappoint. It's really a gift to be able to share such complex things, topics, concepts, and make them so easy to understand. And you're so truly gifted at that. And I have no doubt that every kid or client that gets to work with you benefits greatly, and you can feel your passion for it. And like you said, sometimes these are tough cases and you can get frustrated, but the fact that you hold on to the good pieces inside of these people and hold on to them, then I think that in some cases probably mirrors to them positive, and you see that positive, and the caregivers do. And so it was fantastic. So if our listeners wanted to get more information, can you let us know where could they go to find your work?
Yes, sure. Well, my website is goodthinkingebt.com. So if they wanted to check that out, and it has just a little bit more information about my background and a way of contacting me. That would probably be my number one.
And Psych Hub also has a course on BMT that was done by Dr. Steve Mazza. Just the way that our platform works on these episodes is that listeners can subscribe to our platform and come in and take their post test. So we made sure we hit on all of the topics for their post test. But they also get access to all of that. So they can learn a little bit more about BMT. And I have a feeling you encouraged a lot of us to learn more and to take on some of these more challenging cases or ADHD cases, and make a difference in people's lives that will be able to be there for years and years to come. So thank you so much.
Thank you.
Dylann, you're awesome. It was great having you on.
Thank you for having me.
Thanks so much for listening to Therapy Cafe, the future of mental health. For more information and resources regarding today's topic, please take a look at the episode show notes. If you'd like to obtain continuing education as a psychologist, counselor, social worker, or therapist, you can purchase a 1-year subscription to Psych Hub's learning platform. Once you're signed up, you'll have access to earn CEs for this and every Therapy Cafe episode. Plus, you'll have access to our existing library of over 100 evidence-based practice continuing education courses created by expert clinicians. Go to psychhub.com psychologist.com/sign up for more information.